So our next speaker now is Dr. Mez. So Dr. Mez is an associate professor of neurology. He helps to lead the clinical core at our Alzheimer's Disease Research Center and also a leader of the CTE Center as well. He's going to talk about his or our approaches to treating and diagnosing patients at risk for CTE in the clinic setting.
Hello, my name is Jesse Mez. For those who don't know me, I'm a behavioral neurologist at Boston University, BU Alzheimer's Disease Research Center, as well as the CTE Center. I wear several different hats. Today, I'm going to talk about the BU BMC Memory and Aging Clinic, our approach to patients at risk for CTE. I see patients at risk for CTE. I run this clinic together with Michael Alosco. We see a lot of patients who are at risk, and they engage in research and also receive clinical care at this clinic. I'm hoping that this lecture will provide hope to the families and potential patients listening. And then I also hope for clinicians, this gives you a guide as to how you might care for these patients. And for the researchers, just another sense of how these folks look and some of the issues that they're experiencing. I have no disclosures. So here is my outline. The first piece is just conceptualizing CTE in the framework of a dementing illness rather than as after traumatic brain injury or persistent post-concussive symptoms. We really run our clinic and think about this disease as a neurodegenerative disease, and this is how we approach it in the clinic as well. So I'll talk about the clinical workup, the history, neurological exam, neuropsychological testing, biomarkers. We have traditionally at first a 2-day visit. The first day is where we gather a lot of information and do tests. And then the second day is an informing visit. We spend some time reviewing those results, summarizing our impression, and talking about the therapeutic plan. I'll finish with an example case. The first thing to talk about is conceptually how to think about this disease in the setting of mild cognitive impairment, dementia, and their etiologies. So just some definitions. Mild cognitive impairment is a clinical syndrome defined by a change from baseline in cognitive function, but daily function is still preserved. So activities of daily living are preserved. Individuals are having some impairment on cognitive assessments, neuropsychological tests, which I'll talk about in a couple of minutes. Importantly, this is a syndrome that we see. We're not attributing an etiology. Similarly, dementia is a syndrome. It's defined by a change from baseline in both cognitive impairment and functional impairment. So it's different from mild cognitive impairment in that in addition to having impairment on neuropsychological tests, individuals are also having problems with their function, with their activities of daily living. Potential etiologies for MCI and dementia are defined by their underlying brain pathology, and that may include CTE. So although etiologies of MCI and dementia are defined by their pathology, there are more specific clinical syndromes that often, but not always, correlate with the underlying pathology. So we look at other things clinically, syndromically, beyond just whether there is impairment on testing and whether there's functional impairment. We also look at the pattern of cognitive impairment. So is it a predominant memory picture? Are they having visuospatial issues? And that pattern of cognitive impairment may give us clues as to what the underlying pathology may be. There are also neuropsychiatric features that may be important. For instance, visual hallucinations are something that we see in dementia with Lewy bodies. And then we look for other neurological deficits as well. We look at sleep, movement disorders, etc. And these can all, again, give more clues as to what the underlying neuropathology may be. And then lastly, we have really good biomarkers at this point for Alzheimer's disease, which is the most common cause of dementia. We use those more to rule out Alzheimer's in the setting where we think CTE might be present than to make assumptions about CTE specifically. Without looking at the actual brain tissue, the diagnosis is never completely certain. We talk about how CTE cannot be diagnosed in life. You'll hear that a lot today. You hear it in the news, but this isn't unique at all to CTE. We're never completely certain what the underlying pathology is without having autopsy data. But all of these things that we do in the clinic give us confidence, increase our ability to predict that pathology. Because we have very good biomarkers for Alzheimer's disease, we're quite good at making the diagnosis in life. But even for the non-Alzheimer's neurodegenerative diseases, we still make those diagnoses in life. We have criteria to make the diagnosis not with absolute probability, but likely. And that's really what we're aiming for in the future for CTE. So with all dementing illnesses, neurodegenerative diseases, the current best workup is based on history, clinical examination, formal neuropsychological testing, blood tests, imaging, and potentially a lumbar puncture. It's not like a single biomarker or a single finding that we have when we see a patient gives us the entire picture. The reason this is so complex is because all of these pieces of information are really important. We really drive that point home, why we don't kind of early on when we first start to see a patient talk about the diagnosis is because there's all of these pieces, and we really like to collect all of this information and summarize it before we give our impression. So the history is really the most important component of the workup. Just like the clinicians in the room learn, the history is the most important part of any workup. And we really spend a long time in behavioral neurology and neurodegenerative diseases taking a history. It's really important to obtain a history from both the patient and the informant, and an informant who regularly interacts with the patient. We always ask for an informant to come to the visit, and we say that it's a requirement. I mean, it's not always the case, but it's really important to have an informant provide information because sometimes patients don't have good insight into some of the difficulties that they're having. We start with the question, well, what cognitive, mood, and behavior and or motor problems are you most concerned about? And we leave it open-ended and just listen for a little bit to hear what they're noticing and what they're most concerned about. And then the longitudinal course is really important. When did the symptoms begin? How have they progressed over time? What additional symptoms have occurred and how have they progressed? So once we're finished kind of hearing what the patient and the informant are most concerned about, we then have a bunch of targeted questions. So questions about memory, language, attention and problem solving, visual spatial function, activities of daily living, behavioral dysregulation. So this is the term you probably heard from Dr. Stern. It's one of our central components in the traumatic encephalopathy syndrome research criteria. So this is asking, did they have a short fuse? Are they impulsive? Are they explosive? Can they change on a dime? So that's a particularly important component of the history here. We ask about depression and anxiety, paranoia, delusions, hallucinations, social disinhibition. This is particularly important for trying to distinguish from behavioral variant frontotemporal dementia. And then we ask about motor features and Parkinsonism, whether they've had falls, shaking, tremor, etc. And then we spend some time on sleep as well. Differently from what happens in most memory disorder clinics, but we really think this should be happening, is a detailed history of head injuries, really focused on repetitive head impacts. So we ask detailed questions about contact sports. What type of sport did they play? What level of play? How many total years of play? What position? We also ask about military experience and get at all of these details you see here. So combat, tours, training, operational deployment, length of service, blast exposures. And then we also ask about physical violence, fights, intimate partner violence. And we also ask about concussions and moderate to severe traumatic brain injuries, as you'll hear from other speakers. We really think that these subconcussive, non-concussive, repetitive hits are what's truly important for CTE beyond the symptomatic concussions. So we certainly collect that information, but it's less central. And then we take a careful history, a social history, substance use, alcohol, occupation, marital status, living situation, education. The substance use and alcohol is more of an issue in this population, so a careful history is really important. These other pieces of the social history are important for memory disorders more broadly. And then similarly, we take a careful family history. This similarly is really important for all neurodegenerative diseases because the heritability is high. So we ask about each first degree relative, age of symptom onset, age of death, if they're no longer living, whether an autopsy was performed. And then we also take a careful history of mental illness and substance use. I have that twice. But this is important for all neurodegenerative diseases. I think it's particularly important here because the head injuries are known to exacerbate mental illness, probably independent of a neurodegenerative disease, or perhaps worse in the setting of neurodegenerative disease and the head injuries. So it's really important here to tease that out. We perform a neurological exam. This includes a cognitive screener. We actually, in our clinic, we actually do this as part of the whole neuropsychological battery, but I put it here as most places do it with the neurologist. This is a brief cognitive assessment that can be used in the doctor's office, usually takes 5 to 15 minutes. We use the MOCA, which you can see on the right here, the Montreal Cognitive Assessment. The mini mental state exam is also very common. And then we perform a motor exam. I perform an entire neurological exam, but some of the other components are quite brief. I really focus on Parkinsonism, bradykinesia, rigidity, resting tremor, shuffling gait. But we do look for other things as well that can contribute to the picture. So we may see evidence of motor neuron disease, rarely, but occasionally, and that's really important to note. We may see asymmetry that could suggest corticobasal degeneration. I look at eye movements pretty carefully because of PSP. And then stroke, tumor can often contribute to cognitive issues or mimic a neurodegenerative process. So we have neuropsychological testing built into our clinic. We consider it to be routine part of the workup. We have a standardized test battery that assesses each cognitive domain. It takes about 90 minutes. It uses the same battery that we use in the Alzheimer's Disease Research Center, the uniform data set. And then we add additional tests, which we think are particularly important for getting at issues related to CTE and to these types of patients. The scoring is normalized to a population of unimpaired people, accounting for age, sex, and education level. You can see the battery here to the right. I won't walk through all of the tests, but we get at effort, intellect, attention, executive function, memory, language, visuospatial function, neuropsychiatric features. You'll see we have a pretty extensive self-report and informant report about neuropsychiatric features, given that we're talking about CTE. So we get at issues of depression, apathy, impulsiveness, behavioral dysregulation. And then we also have a measure of function, the functional assessment questionnaire, which starts to get at whether or not there might be functional impairment dementia present. Neuropsychological testing really has three functions that are really important to emphasize. First, just whether or not there is objective cognitive impairment when we sit you down in a quiet room. And then second, it tells us about the severity of the impairment. Is this mild, moderate, severe? And then, as I mentioned before, the pattern of impairment is really important. Is there relative sparing of particular cognitive domains or certain cognitive domains particularly impaired? That gives us information as to what the underlying pathology may be. We also regularly obtain imaging, almost always a structural MRI. This is FDA approved, routinely covered by Medicare. It's really a routine part of the neurodegenerative workup. It gives us a lot of information. So we look for patterns of atrophy or patterns of shrinkage. We also look for microvascular disease, microhemorrhages. We also look for other causes of neurologic deficits, which might be confounding what we're seeing. Most people are able to do the MRI. Claustrophobia can be an issue. We can prescribe medications to help with that. If individuals have metal in their body, this uses a magnet, so they may not be eligible. We use FDG PET less commonly. So FDG PET is an imaging modality that looks at glucose uptake in the brain. So we see reduced metabolism in areas that may not be functioning as well. And that pattern can give us information about the underlying neurodegenerative disease. It's FDA approved, only covered by Medicare if we're trying to differentiate frontotemporal dementia from other types of dementia. This is a question we often have in the setting of potential CTE. So it is a valuable tool, and it has low level radiation exposure. We pretty commonly now use biomarkers for amyloid and tau, specifically getting at whether or not Alzheimer's pathology is there. These are very effective tools. They don't tell us information about CTE as much as telling us whether or not Alzheimer's pathology is present. In run-of-the-mill Alzheimer's disease, we often won't use these because the syndrome is pretty classic. We don't think that there's other etiologies, or we're pretty sure about the pathology. But in the setting of our clinic, where this is a really common question, because CTE is so on our radar, we use this a lot. Most of the time, we use lumbar puncture. There's a couple of reasons for that. It's FDA approved, covered by Medicare, it's inexpensive. It provides information on amyloid, tau, and neurodegeneration. The biggest concern is that it's invasive. It really isn't that different than a blood draw. We work with one of our other neurologists who does these all of the time. I do them as well. You don't have that much sensation in your lumbar spine. The biggest discomfort with it is just staying in position rather than pain. The other way of getting an amyloid pathology is a flubeta-peer PET scan. This is FDA approved but not covered by Medicare, so it tends to be expensive in individuals. Unless we can cover it through research, which we often can, it can be expensive and you need to pay out of pocket. There's low radiation exposure as well. And I'm sure you'll hear more about this from our other speakers. So then once we do the assessment, we have our informing visit, and our informing visit is typically a separate day. We spend about 45 minutes or an hour talking through all of the results. The informing visit has three parts: the review of the results, all of the things that we just went through, as well as a discussion of the diagnosis. We talk about the syndrome as well as the etiology, and then we talk about a therapeutic plan. So this is an image we often will show to our patients, just giving them a sense of the fact that this is there's slow progression of neurodegenerative disease. We talk about mild cognitive impairment, the different stages of dementia. We also talk about preclinical disease, this idea that neuropathology in neurodegenerative disease begins accumulating, for instance, in Alzheimer's disease, as much as 15 or 20 years before symptom onset. We think this could very well be the case in CTE as well. So we just talk about this, what we understand about the progressive nature of the syndrome. And then we talk about the etiologies of what we are seeing. So this can be reversible causes, things like hypothyroidism, vitamin B12 deficiency. I didn't mention, but we always do check for thyroid disease and vitamin B12 deficiency. These uncommonly are the reason that folks are having cognitive impairment. They may be contributing. They are common, and they are common in that they're common in the population. They are uncommonly the reason that folks are having cognitive impairment. But they are very reversible, and we always look for them, and they're easy to treat. We talk about depression as a potential reversible etiology. Oftentimes, the medications, the psychoactive medications that individuals are taking can be contributing to the cognitive symptoms. And then we talk a lot about substance use as something that can be reversible. And then we also talk about the different neurodegenerative and progressive potential etiologies, which you can see here. Again, Alzheimer's disease is the most common in the general population. Individuals who come to our clinic often have overwhelming repetitive head impact exposure, making them high risk for CTE as well. A really important concept is that a single neurodegenerative disease doesn't occur in isolation often, is what we've learned, and that often multiple pathologies are contributing. So this is another concept that we talk about, that multiple different pieces could be contributing to their clinical syndrome. So then we talk about the therapeutic plan. A really important piece is general psychoeducation. So just giving them a sense of what we did, what the diagnosis is, that even though there might not be a disease-modifying therapy, we have a really long list of ways that we can intervene, both separate from drugs, but also including symptomatic treatments. So just walking through this whole piece conceptually and why this is a valuable experience, that in and of itself seems to help an incredible amount. So we spend a lot of time on mood and behavior. We'll refer to talk therapy, particularly cognitive behavioral therapy. We often will refer to geriatric psychiatry as well. We work closely with Wendy Q, who is a geriatric psychiatrist at BU. I will oftentimes prescribe SSRIs, depending on the situation. These folks have a lot of pain as well because of their orthopedic issues, so duloxetine is often valuable. And then rarely I'll use quetiapine for agitation and for sleep. From a cognitive standpoint, we really emphasize non-pharmacologic behavioral changes. So these are things like making sure you're making lists, having a pill box, recognizing when you have difficulty and coming up with strategies to avoid those types of situations. If we think Alzheimer's disease or dementia with Lewy bodies is also present, or if the biomarkers are positive, or if syndromically we're pretty convinced, then we'll start a cholinesterase inhibitor and memantine. If the biomarkers are negative and syndromically we think this looks very much like CTE, we typically don't start a cholinesterase inhibitor. We also reconcile medications that may be affecting cognition. Because the mood and behavior is such a big piece of this disease, we often have individuals coming in who are on a large cocktail of psychoactive medications, and it's this risk-benefit weighting of whether we should stop those medications or not. I mean, and then we look for things like antihistamines, anticholinergics, which might be contributing to difficulties with cognition. We try to avoid benzodiazepine. We send to the PCP for low B12 or abnormal thyroid function. We talk a lot about sleep. We talk about good sleep hygiene, using your bed only for sleep, not for other things. We'll refer for sleep studies. We really, a lot of these, because these individuals tend to be large and at risk for obstructive sleep apnea, we have a lot of individuals who come in already with this diagnosis, and a lot of them aren't using their CPAP. So we emphasize the importance of using CPAP. Melatonin is a benign, safe drug. Your body makes it itself. We often will recommend melatonin to help with sleep. I said previously we try to avoid benzodiazepines. That being said, clonazepam is recommended for sleep behavior disorder. It's rare that I prescribe it, but on occasion. And then the quetiapine is good for sleep if they're also agitated. It's rare that I use it, but occasionally. If they're having motor issues, either because of Parkinsonism or because of their orthopedic issues, I'm quick to refer to physical therapy. We often will also work with our movement disorders colleagues and refer to movement disorders if we think that will be helpful. Sometimes when we're not sure about the movement disorder that we're seeing together with the cognitive disorder, then their input is really valuable. We talk about motor vehicle operation. We have a low threshold to recommend stopping driving, understanding that it is often taking away an individual's independence. If there's questions about their driving ability or conflict among family members, we'll often use send them for a driving evaluation. We really emphasize healthy lifestyle. So exercise, the American Heart Association recommendations, I'll mention it just about every visit. Talk about a Mediterranean diet. What's good for the heart is good for the brain. I say that at every visit. And then we talk about the importance of social and intellectual engagement. If needed, we'll talk about safety at home, referral to elder services, physical therapy, occupational therapy. And then we always talk a lot about social support. So the Alzheimer's Association deals not just with Alzheimer's disease, but with related dementias. And their resources are vast and wonderful. They're everywhere. So I can't recommend them enough. The Concussion Legacy Foundation is also wonderful, has great resources, very specific to CTE, a lot of support, and we also recommend them. We also talk about the caregiver, which is really important. So support groups, respite, that care only works when the caregiver is getting what they need as well. There are a lot of caregiver resources, both with the Alzheimer's Association and the Concussion Legacy Foundation. And then we talk about an advanced care plan, and so end of life planning with everybody, not so much that that's going to happen imminently, but that this is, even for folks who are completely cognitively normal, this is an important part of planning for the future. I want to finish with an example case that we just saw very recently. This was a 69-year-old gentleman, former college football player. He had 8 years of play. He was a defensive end. So he had a decent amount of play, but not overwhelming. He didn't play in the NFL, but he did play in college. He didn't play much in youth. He had angry outbursts beginning in his 40s, increasing in frequency and severity, currently occurring a couple times per month. He also had apathy, low energy, and then he was also tangential with expressive and receptive language difficulty. With probing, he also had memory and executive function complaints. And these cognitive complaints have been progressively worse, particularly in the last 5 years. Functionally, he was largely intact with subtle concerns. He was taking multiple medications that could have been complicating his or contributing to some of his cognitive difficulties, phentermine, diphenhydramine. He had a normal neurological exam. He had neuropsychological testing that showed impairments in learning and memory and phonemic fluency. You can see there the phonemic fluency. Wordless learning he had difficulty with. And then he also had elevations on self-report of anxiety and depression. Interestingly, impulsiveness, despite that history, was not elevated. And then on his FAQ, his functional assessment questionnaire, there were subtle functional issues that I didn't really pick up on the history, but kind of sub-threshold for dementia. He had an MRI, which showed mild to moderate cortical atrophy, no hippocampal atrophy, a small anterior cavum septum pellucidum, mild white matter hyperintensities, and no microhemorrhages. I have his two cuts from his MRI on the right here. You can see pretty marked, actually, posterior cortical atrophy, which is more of a pattern we see with Alzheimer's disease. So that did raise our suspicion. On the second coronal image, you can see the small cavum septum pellucidum here. Also, if you look at the frontal lobes cortically at the top, there also is probably more atrophy there than we'd expect for someone of his age. He had laboratory testing, which showed normal thyroid and borderline low vitamin B12. He had a lumbar puncture to look for biomarkers of Alzheimer's disease, which showed elevated A beta or normal A beta 42, which abnormal is low. So this was particularly high, so inconsistent with Alzheimer's disease. Interestingly, his total tau, so a marker of neurodegeneration, was elevated, and his phospho-tau was also elevated. So these are markers of tau pathology and of neurodegeneration. We look at the p-tau to A beta 42 ratio, but because the A beta 42 was so high, we couldn't use that ratio. But this picture was inconsistent with Alzheimer's disease, but we are seeing evidence of at least neurodegeneration here, which seems consistent with what we're seeing on the MRI. So in terms of therapy, we talked about what we saw, we did a lot of psychoeducation. We discussed how the phentermine and the diphenhydramine could be impacting his cognition. We talked about how stopping may be beneficial, but we needed to weigh the risks and the benefits. He was specifically taking the diphenhydramine because of secretions related to his CPAP. So I wanted him to use his CPAP, so it was a little bit of a discussion. Given his biomarker profile, we did not start any medications for Alzheimer's disease. We talked about non-pharmacologic behavior changes. He was coming from out of town, and we obtained a referral for psychiatry through the Concussion Legacy Foundation. And we also recommended talk therapy. He wasn't on any medications for mood. We talked about how an SSRI would probably be valuable for him, and that could be prescribed by his psychiatrist locally. And then we also recommended that his primary care doctor replace his vitamin B12. We talked about all the healthy lifestyle recommendations that I already mentioned. We talked about sleep, the importance of good sleep hygiene, the importance of using his CPAP. And then we recommended the Alzheimer's Association and Concussion Legacy Foundation resources. So In closing, I did go a little bit over, my apologies. It's really important to use this neurodegenerative framework, I think, rather than persistent post-concussion symptoms. I said that in the very beginning, but this is a really important approach to dealing with these patients. And then just driving home this point, the current best workup is based on all of the different assessments we talked about. A single piece of information is not sufficient. The point that psychoeducation goes an incredibly long way, can be really effective. I can't emphasize that enough. And then this idea that although we don't have disease-modifying therapies for CTE, there are many effective non-pharmacologic and pharmacologic symptomatic treatments, and we went through those in a lot of detail. The other really important piece is we are really closely integrated with our research. Almost every patient who we see in the clinic is also a participant in research, and we leverage our research infrastructure to concurrently provide clinical care and to conduct clinical research. And this provides really mutually beneficial opportunities for patients and investigators. And this is the way that our clinic survives, both financially and I would say intellectually. So I can't emphasize, that's a great tip, or we think it's really useful as well. So here is, the last two slides I've included are just information about our clinic. And, we see folks locally for ongoing follow-up, as well as providing one-time or annual consultations for folks who come from out of state.